with an NNT of 90. Sorry about this. But the mortality wasn't affected. So these acute geriatric units didn't save lives, you know. And in length of stay, we saw a difference in the length stays of around 1 day saving patients who went to the acute geriatric union. And most of the same results in randomized controlled trials and in non-randomized controlled trials. For cost, we also, not cost related to the length stay, because the cost, most of the cost for hospitalizations, about 70% of all the cost came in the first 2 days, 3 days of hospitalization. So it doesn't relate to shortening the length stay, but for other issues. So, well, that's our main results. What has happened in the next years after our publication? Things are more the same. This is data from the meta-analysis from Fox that it was in an acute, in an ACP journal, commented by Tinetti. And so there's, according to this meta-analysis, acute geriatric units reduces falls, reduces delirium, functional decline, but it doesn't it reduces mortality, neither readmission 3 months later. You know? This is data also from this same group of researchers that they saw that there is a saving of costs. And I will finish now with some data. So I was asked to talk about some implementation of what are we doing. We have the data, and what was going to happen with all this data. Well, I think things haven't changed a lot. So I know that the best country to have been improved all these geriatric cares is in UK, but at least in UK I've seen that only 3% of geriatricians attend these old people, but in 85% of the UK there is a geriatric department, and things are not the same here. Well, this is where I work. I work in a little hospital, but I'm part of the big hospital. It's 5 kilometers from where I am, and we have 2 different acute geriatric units, but quite the same. They're working the same. We have the house officers. They go all along through the big hospital to our little hospital, and you can see here what are the length stays: 7 days, 77 days for Canto Blanco is the name of where I used to be, and I am now. We have almost the same occupation, and as I said, our average age is about 80-something, 88, and with not very good. Yeah, this is the last ones. So you can see what's the Basel Bartel, 48 in Canto Blanco versus 64 in La Paz. No? And so that's my last slide. So we say that acute care, I think there's no way to discuss its benefits, but so from the other ways of caring acute illness in elderly people is the best way of the other models, and it must be this must be done in a architectural unit with a multidisciplinary geriatric team focused on the prevention, immobility, malnutrition, delirium, falls, infection, trying to preserve function, and a very compromised team trying to do all these things and trying to discharge planning. Thank you. Well, I wanted to show you my team and my hospital, but okay, later. Oh yes, 100 years. Yeah, 100 years. This is it. This is now. Only 3 of our team. Okay.
Okay. Thank you very much, Dr. López Arrieta. We are going to pass to the second speaker, Dr. Graham Ellis from Scotland.
Bon dia. I have now used all of my Catalan. Miguel has been trying to teach me, but I'm a poor student. I think I must begin with an apology. It seems that I brought the weather from Scotland to Barcelona to make me feel at home, but it's a privilege to be here today. And with some more apologies to our speakers this morning, this is my very simple understanding of frailty. We understand more about risk factors for frailty and how we need to prevent it. But much of our role as geriatricians is intervening to try and prevent a minor health crisis leading to dependence and always trying to maintain independence. And I've always loved this quote by Kenneth Rockwood on frailty as my simple understanding of it. You've seen one of these graphs already. This is the Scottish population profile. We're expecting the population of 85-year-olds in Scotland to double in 20 years. And we don't know whether we need to build more golf courses or more hospitals. Perhaps if we build more golf courses, we won't need so many hospitals. And this is, again, data from Scotland illustrating that as you age, your risk of comorbidities increases dramatically, so that multimorbidity is more normal in the elderly. Similarly, this time taken from the Electronic Frailty Index paper from 2016, you can see that the correlation between age and anything from mild to severe frailty is a very strong relationship. This again is Scottish data looking at medications. As your multimorbidities increase, your prescribing increases, and your risk of polypharmacy increases. And along with that, drug interactions, as you might expect. So in fact, the only job to have in the future is to be a geriatrician. And you need to lobby your government for more geriatricians, so that this time next year, you have double the amount. But you know the definition of comprehensive geriatric assessment. This is the full original definition by Lawrence Rubinstein. Sometimes I think there's a temptation to focus on the assessment and the diagnosis, but it is also about the intervention and the therapy to improve outcomes. And in green, I've really written my rather simple definition. It is organized, coordinated, specialist multidisciplinary care. So this is what we do. This is our bread and butter. And really, just to give you the updated meta-analysis from the Cochrane Review, it's nice to have 9 countries included this time round, 3 more countries, 3,000 more participants. And really, this is a broad, comprehensive review, which includes acute geriatric units, but also consultation teams, step-down units, and so on. So it is a broad church, as we would say. And really, to highlight the results in simple form from this review last year, the basic message is the same. Anyone in receipt of comprehensive geriatric assessment is more likely to return home alive. And this time round, as with Jesus data, it's nice to be able to look at the point of discharge. Patients are more likely to go home to their own house on discharge from CGA. And so the effect of the intervention occurs early, and that may be crucial, that we get in early. And the impact on nursing home admission is more significant too. Now, we looked at the processes, the components of CGA, what's called the black box, to better understand what was involved. And we tried to divide that into looking at the members of the CGA team and the processes of care, if you like. So we looked at the subsets between mobile teams and wards and tried to get a better understanding. It's interesting that in the meta-analysis, there seems to be no positive subgroup or trial of CGA teams, and it may be simply that that's underpowering. But we wanted to understand what are the key components of CGA and what makes that crucial difference. And just looking at what's published in the literature, there are some slight differences in terms of the organization. Wards seem to have a slightly more organized care. There also seems to be a slight difference in the number of core team members. And some of the papers described having better control over the recommendations. So you make a diagnosis, you make a recommendation, but you follow through and you deliver that recommendation in your team. And one final element which may be important but isn't explicit is this idea of the nurse who looks after you on the ward being expert in the care of older people. So these may be important. We also asked the trialists, we sent them a survey and we asked them to tell us what was in their experimental group and what was in the control group. So here we're looking just at the staff between the two groups. And apart from differences in the number of senior or consultant geriatricians, broadly the groups are similar, which is very interesting. So what is it that makes a difference between the ways the control group and the experiment group work and behave? And we explored this in discussion with the trialists. We also asked them, in interview and survey, could they tell us what they felt was key to CGA working? And it's interesting that tailoring the treatment plan to the patient comes out as the strongest thing. But elements of team working, team leadership are also crucial. And specialization doesn't come out as the first on that list. So we then had a discussion with trialists. We brought some of them to a meeting, and we asked them further questions. And one of the questions I was very keen to explore with them was this idea of team working and what we call non-technical skills. Now, in Britain, in elements of acute care, we've become more conscious of the importance of what we call non-technical expertise. And this is learning from the airline industry, where they examined what was the cause behind airline crashes. And often it wasn't the skill of the pilot in flying a plane, it wasn't their technical skills. It was often to do with their communication, how well they worked as a team in the aircraft. And so we're now exploring this in elements of acute care in medicine, looking at elements of how a team operates together, whether they communicate well, whether they are coordinated, whether they have clear leadership and clear understanding of each other's roles. And so we've been exploring this in some of the acute areas, including anesthetics, emergency medicine, and surgery. But I think that these elements of ways of working apply well to geriatric medicine. And so we put this to the trialists in a discussion. And they felt very strongly that the way in which a team works was at least as important as what the team knew. So this was very interesting for us. This is an anesthetic framework for evaluating trainees. So these categories on the left, task management, team working, and so on, are used to assess the quality of training for a trainee in anesthetics. But I think you can apply them to geriatric medicine and to training in the specialty. And I used to have a role as a manager, and many of the complaints that I saw from patients and relatives reflected some of the lack of skills that the team had in working together, communicating, identifying when there are problems and risks, and managing them. So I think these elements are going to be key to how we perform in geriatric medicine in the future. And I'm very keen to try and introduce them into medical training. But I want to shift from just looking at CGA in medicine and just bring out some of the evolving literature in other areas. So I'm going to briefly touch on surgery. Although the population is aging, the number of people undergoing surgery is increasing more rapidly than population aging. So more older people are having surgery due to perhaps advances in surgery, minimal interventions. And many people who are old benefit from surgery if they can have access. And we had that illustrated this morning beautifully. But older people and older people with frailty are at far more risk of complications from surgery, anything from wound infections to delirium. And these complications can be catastrophic. You're probably aware of work going on in the UK and in London. They looked at the POP study trying to look at preoperative assessment. If you identify manage risk in a preoperative assessment arena, you can reduce complications post-surgery. We tried to replicate that work with much less money, but just introducing a nurse into the preoperative screening stage who had expertise in dealing with frailty, reduced complications after surgery, delays to surgery, cancelled surgery, and lengths of stay. So there are opportunities for us to do more in the realm of surgery. This Cochrane review was published just in January this year and looks at 7 randomized controlled trials, most of them, 7 of them in orthopedics, but 1 in non-orthopedic surgical care. And again, demonstrating that comprehensive assessment and management reduces that risk of institutional care long-term, but also helpfully reduces the risk of delirium by the point of discharge. So there are real potential areas of development and benefit for older people in other realms, including surgery. This is data from the Cochrane Review on Orthopedics, which is now really quite out of date, but we need to update this and add more to our knowledge on what works well. But what about the emergency department? We talked about the opportunity of getting in early to introduce CGA to people. What about the opportunities in the emergency department? There's increased risk for older people in the emergency department. Many of them arrive by ambulance, they're more sick, they're more at risk of staying in hospital, and the consequences of hospital care, as we've discussed, are very significant potentially. And older people are more likely to wait in hospital. This is data I just analysed last week from Scottish data on 1.5 million attendances at the emergency department in Scotland, the whole of Scotland. And it looks very like the older you are, the more likely you are to wait in hospital. So if you're a baby, your risk of breaching that 4-hour target is quite low, but if you're over 85, that risk is as high as 1 in 6. Now, some of that relates to the need for admission and the wait for hospital beds, but some of it may be due to the complexity of our patient group and the complexity of assessment in an emergency care setting. So there may be more opportunities to intervene. And again, another quote that I love from Kenneth Rockwood, describing the fact that we gear our systems for a patient group, but we sometimes don't recognize that older patients are, in fact, our core business. Falls is not just a problem in the community, it's not just a problem in our wards, it is a presenting scenario at many of our emergency departments, and therefore represents an opportunity to intervene. 1 in 5 of our attendances at emergency department are due to falls, so there's an opportunity to intervene and prevent recurrent falls and fracture risks. And care home residents, nursing home residents, some of our most vulnerable frail elderly patients are more likely to be admitted to hospital, but they have often poor outcomes in hospital. So there's an opportunity to do something better with their care. And finally, in terms of medication, and this was one of the reasons that I became more interested in doing more work in the acute setting, is that not only is polypharmacy and medication prescribing a reason for presentation at hospital, but poor prescribing in hospital in the early hours of hospital admission can have consequences later on. We had large problems with Clostridium difficile infection in Scotland, and often that first antibiotic dose in hospital, perhaps given to someone who didn't need it, can have consequences later on. So we became really interested in could we intervene before things went wrong? And for many of the patients who are coming to the hospital, could we avoid them being admitted at all because there was an opportunity to improve outcomes for them? So there's more work needed in the emergency department because I think that the early hours of arrival at hospital could be crucial to the consequences of hospital care that follow. However, I want to talk about hospital at home. Could we in fact move out from the hospital? We started at the back door of the hospital, we've moved further forward, and in fact I now run a hospital at home service in Scotland and want to talk a little bit about the evolving evidence base there. So hospital at home has a clear definition and is primarily around replacing the hospital. So keeping the elements of CGA, keeping the elements of teamwork and specialist intervention, but taking away hospital walls because we know that there are potential reasons that that can be harmful in the elderly. We know about hospital-acquired infection, and we worry about the functional decline after admission to hospital, and we know that delirium can be caused by hospital as well. So there are reasons that redesigning our systems may be of benefit to older people. And in fact, this is the data from the Cochrane review just 2 years ago, showing that there is a possible reduction in mortality associated with hospital at home. Now, we would recognize that the total number of patients in this analysis is quite small, but it raises a really challenging question about the way we deliver care. And I want you just to think about the question, what if that was true, that being cared for at home could be safer? So these are some of the members of my hospital at home team, and they come from different disciplines. We had to construct a hospital at home service without enough doctors to provide the care that we would expect. So we recruited different disciplines and brought them together. And in fact, all of these members of the team are able to examine and to make diagnoses as any junior doctor would in a hospital setting. And so we created this blended team. This is summary data from last year looking at our service, and we've been running for 6 years now. But we manage 80% of our patients in the home. We take patients directly from GPs as an alternative to hospital. And we're currently covering a 500,000 population. I think that's probably smaller than your service, but it's for us an evolving picture. And we're quite excited about trying new and acute ways of working. We have oxygen and IV therapy at home, blood transfusion. But we're excited about exploring the idea of remote monitoring for blood pressure, pulse, temperature. We're starting to use more and more video conferencing to diagnose and communicate with patients, and hoping to explore point-of-care testing so that we can be both more timely and more accurate. And we currently have an ongoing trial across the UK, trying to recruit 1,050 patients, so we have about 30 patients to go. And we're hopeful that this will add to our existing evidence base around the safety and the cost-effectiveness of hospital at home. So I want to just give you some opinions, if I may, to finish, on the hospital in the future. In the UK, in the old days, we used to have thousands and tens of thousands of hospital beds. And you could measure length of stay in Marjorie Warren's time in months or even years. Procedures were major. They were often done with a sword. There were big scars. Recovery was prolonged and survival was poor. And back in the good old days, the doctor was king. However, we're now looking at very changed hospital care environments. We're now measuring length of stay in hours We have fewer numbers of hospital, and we are certainly far fewer beds than we used to have. And we're looking more into minimally invasive treatments, whether that's laparoscopic therapy or replacing surgery with medical treatment. And nowadays, in our legislature and in our culture, the patient is king. So I want to offer a few opinions about the future for hospital care, if I may. Firstly, I think hospital care or specialist care needs to be agile, by which I mean it needs to be both mobile and responsive and flexible. You can now have nearly anything from pizza to shopping delivered to your house, so we cannot live with the idea that institutions are the place for healthcare. Secondly, I think that healthcare needs to be intelligent. We have lots of data, we have quite a lot of information, but we don't always have intelligence. And so we need to be increasingly looking at machine learning and artificial intelligence and ways of understanding situations better. We're quite excited by simple things such as the electronic frailty index, which takes routine diagnostic data from a general practice and through a simple algorithm is able to determine someone's individual frailty score and risk of future care. But we need to get a lot smarter in how we do things. And then I think healthcare needs to be personalised. It can no longer be that one size fits all. In Scotland, we've been trying to major on this concept of what matters to you. So the outcomes of care, the focus of care, what we're trying to do has to be about what matters to you. So above every hospital bed in Scotland, you will see a board, and on that board it says, what matters to me? And the nurses have to write down, after discussion with the patient, what are the things that matter most to them? Whether it's family, whether it's faith, whether it's pets, whether it's hobbies. And so that is now the culture we need to move towards. I do think that we need a new workforce. We've found tremendous benefits from blending skills between nursing, AHP, and medical workforce. And we've found that these new types of ways of working bring additionality. So not just the traditional roles of occupational therapy, medicine, and so on. Blending and combining workforce, making more dimensional workers, has been hugely helpful for us, and I think represents the way in things may shift in the future. And finally, I believe very strongly that the healthcare for the future, and particularly in geriatric assessment, has to be about those non-technical skills, how we work together as a team, how we coordinate care, how we deliver care, and how we create the cultures and environments that are best for our patients. Gracias.
Thank you very much, Professor Graham Ellis. Now the next speaker will talk about geriatric assessment in setting community, Dr. Michael-Angel Mas. Thank you.
Thank you, Professor Miralles, for your introduction. In my lecture, I will talk about several CGA-based interventions designed to provide care to high-risk older patients in the community. CGA is key on preventive home visits and on the management of older people with multiple chronic conditions. CGA should be a key tool for the future integrated care system. Based on a report of WHO in 2015, integrated care must be provided based on CGA. In an integrated care system, we should focus on people and their goals. The main goal is to maximize intrinsic capacity in a scheme on when older people is an active participant in care planning and in self-management. Based on the community strategy on frailty, several authors are suggesting that frailty screening should be followed by access to CGA, and that CGA delivery should lead to reduction on frailty-related adverse outcomes. Focusing on multimorbidity, several authors are defining interventions to targeting function, to shared decision-making, to impact on medicine management and self-management. Should be CGA a good opportunity to do that in primary care? There is an ongoing protocol, Cochrane protocol, describing and defining CGA intervention followed by multidisciplinary team interventions tailored to high-risk, frail older patients. This group of patients are not acute patients and are patients in the community at risk of negative outcomes. I think Graham is involved in this research, so you need to come back to Barcelona, and we will share the discussion of these results. Looking at micro-level experiences, we found that CGA is key for different care models to several profiles of older patients and settings. I will highlight on several interventions, on interdisciplinary primary care, on case management programs, on preventive home visits, and on geriatrician-led hospital at home. A systematic review and meta-regression analysis published by Stack in 2002 found that programs of preventive home visits appear to be effective if they are based on multidimensional geriatric assessment, if they include multiple follow-up home visits up to 9 visits per year, and targeting persons at low risk for death. Benefits on survival were seen in young older rather than old populations. In another systematic review and meta-analysis, in 2008, the results on mortality were confirmed, and we found that results on functional decline were based on multidimensional assessment followed by clinical examinations. Effects on nursing home admission were heterogeneous and were depending on multiple factors. These authors conclude that effectiveness depends on 4 major factors: on intervention program characteristics, on population characteristics, on adherence, and on every local health setting. Another systematic review and meta-analysis published in 2008 confirmed these results. They found stronger evidence for community-based services to older people after hospital discharge. On the other hand, in older patients selected as frail, intervention could reduce hospital admission, and fall prevention interventions led to positive effects on several outcomes. Let's focus on an example of complex interventions from a Catalan group. This is a group of primary care professionals. It's interesting to focus on the assessment tools. Notice time get and go test, min-examination of cognitive status of Lobo, and FRI criteria. But also, it's interesting to focus on intervention. This multidimensional intervention includes structured physical activity. This is an aerobic program, protein intake, memory workshops, and medication review. They found improvement on functional and cognitive performance at 12 weeks, and the effect was significantly maintained up to 18 months. So it looks so impressive from a geriatrician perspective to notice that there are several groups in the community that they are designing and performing this kind of complex interventions to frail older patients. Let's move on to care management programs. These were a solution for older patients with high needs. They are based on targeting high-risk populations and using risk stratification models. This found impact on several outcomes, not only on urgent hospitalization, but also on several other clinical outcomes and other outcomes from the quadruple aim. This is a very interesting slide to focus on this intensive primary care intervention. You have 3 models of primary care interventions. The first model is home-based replacement. This is the logo of Veterans Affairs home-based primary care. The second model is the outpatient model of guided care. And the third model is the augmentation model of GRACE team care. These schemes are useful to have an impact on hospital admissions and on quality outcomes. And let's have a look to more details on these 3 models. Home-based primary care, notice that are based on multidisciplinary teams. They use CGA and CGA-based protocols to provide care plans. Guided care was based on registered nurses programs, and its assessment include validated tools from CGA to perform, again, care plans. The GRACE team care model is very challenging because from a perspective of responding to complexity is so comprehensive. Initial and annual home visits were performed based to provide CGA. And there is a strong support team supported by a multidisciplinary geriatrician-led team to provide care plans in collaboration of GPs. Only 3 slides on the other scheme to provide intense care, not to chronic condition, but also to crisis in chronic, in multimorbidity and in frail older patients. noticed that the majority of hospital-at-home programs evidenced on the literature are based on geriatrician-led multidisciplinary teams. And we know that they are using CGA-based protocols. Here in this slide, we have two examples. Graham, this is your UK model, and this is our Catalan model. Sorry for the but when we compare, there are not the same kind of design, but when we compare, we show that CGA at admission was performed as a way to provide multidisciplinary assessment and care from the hospital wards to the community. When we focus on several tools used, we have functional assessment, we have cognitive assessment, we have morbidity assessment. So from a geriatrician perspective, these schemes are absolutely the same that in hospital ward, but moving to the community. Our work on this topic at Refit Group in Barcelona was an opportunity to adapt your model, your British model, to our region, and we found positive results on several processes. We found positive results on orthogeriatric care, on the management of disabling health crisis, and on avoiding admission in medical patients referred directly from the community or from emergency departments. So CGA should be key for the future integrated care system, because if we want to provide integrated care in the community, it is essential to provide a comprehensive geriatric assessment to detect needs and to define care plans for complex patients. This slide is from our project in Metropolitana North, in the Catalan Health Institute. We are planning to develop an integrated care program to older patients with complex chronic conditions. Based on the literature, we found that CGA is key for every single stage of the care process. CGA is key for the stage of identification of needs, for the stage of follow-up, for the stage of health crisis management, for the stage of transitional care, and for end-of-life care. So CGA should become standard practice. Clinical expertise is needed, but that's not only our expertise. Geriatric expertise need to be expertise of all the health system, all the actors of the health system. We need to provide multidisciplinary and multi-specialty care for case management, and with an iterative process of assessing and reassessing based on CGA. To conclude, CGA is used in different ways in the community, in preventive home visits, in hospital at home, in home-based primary care. Several evidence-based approaches showed positive results on different clinical outcomes and on cost effectiveness. The most important point is to provide CGA followed by multidimensional, multidisciplinary interventions. And the most challenging point is to keep doing things and trying to answer remaining questions. What is the most effective CGA-based approach? Who benefits most? What outcomes can be most improved? What are key program elements? How could we be cost effective? And an important question, is it possible to integrate community-based CGA into the health system? Thank you very much.
Thank you very much for all three speakers. We have just the time perfect, all three speakers. And perhaps we have 10 minutes for if there are some questions. Dr. Marco Incitari.
Thank you to everybody. That was a great symposium. I would like to take advantage to have Graham here and ask him about the hospital of the future. You showed perfectly which should be the characteristics and what we should talk and work on. And you also had experience as a manager of an institution. So do you think, and this is probably a provocative question, that we really need more geriatricians or only need more geriatricians or seeing the cross-sectional, let's say, reach of the old people and the things that you showed there, which is the role of the geriatrician there? It's to care, to disseminate, and where should we start from? Sometimes when we think about not only geriatric services, but particularly other services, we need so much to do that it's even hard to understand where we should start from. We cannot do everything at the same time. So which are the real priority, or where we should be the first thing to do?
Thank you for a very difficult question. So yes, no matter how well provided you are with geriatricians, when you look at the evolving literature, it seems that CGA works in so many places that ultimately we're going to have to make some difficult choices. I think there are probably two questions within that. One is, what can only a geriatrician do? And the other question is, what should everybody else know? So, and I think we have to be careful. There are areas where really the evidence is strong that geriatricians make a difference. So for inpatient care, I think that seems clear for medical admissions. But I think we need to be increasingly educating fellow physicians, general practitioners, and others in frailty, older people, and comprehensive assessment methods. So I think we need to do more to integrate into undergraduate and postgraduate training how to look after older people with complexity. And I think the third area is I think we are going to have to look at new forms of workforce. We're going to have to get more multidisciplinary. We're going to have to train new members of teams. We've had experience with nurses and therapists who very quickly adapt to a geriatric way of thinking, who are able to be multidimensional, who are able to be holistic. And so I think we are going to need to diversify the workforce. For instance, in our surgical work, I had very little time allocated to surgery, but involving nurses and therapists, they were able to expand our reach into the specialty without expanding my time commitment. So I think it's got to be all of those elements.
More questions? Well, in the same line, I would ask if we have to work in a community primary area, and we can to implement the geriatric assessment and in integrated care community, which would be the most important key component to begin, because we have no geriatricians in community. And then I think it's in the same line that your answer, but what do you think would be the best key component? The intervention of physiotherapy, pharmacy, which would be?
Okay, easy questions today. So it's similar to the last question. I was doing inpatient work. I had management experience and responsibilities. I started working in the emergency department, and our board director wanted us to move into the community, and I couldn't do both. So I stopped working in the emergency department and moved out. But we recruited this team to work with us, and so that I'm able to direct a team of people in terms of how they assess, how they diagnose, how they manage a patient. I think probably the team with the right skills is the crucial thing. I know that's a big answer to a very specific question. So I think recruiting the right people, equipping them with the technical and the non-technical skills, and ensuring that you have very close working with them means I think you're able to do more. We've actually closed some of our intermediate post-acute care beds because they started becoming empty as we were moving into the community. So we recouped some of our resource for that shift. And I think it's going to be a continuous process of moving forward and then recouping resource. But it definitely needs that team, I think.
Okay, thank you. Thank you. Questions? Dr. Morandi?
Thank you. So the question again is for Professor Ellis. So I don't know if I actually missed this part, but do you have any data on delirium valuation, delirium duration with the home hospital in like your program?
Obviously, you know, Scotland has a very passionate leader in delirium, and obviously we use the 4AT tool and with strong presence from the European Delirium Association. In both the trial and in practice, we have quite a strong emphasis on delirium recognition and management. In practice, first of all, we're using the 4AT, and it is one of our standards of care that it must be routinely used, and in fact that following through on management should be used. Not sure how well we do on that, but at least we're recognizing the need to do it. In the trial, the suggestion for some of the potential benefits of hospital at home, even on mortality, is the possibility that the incidence and prevalence of delirium or the duration of delirium might be less severe because you're managing in a home environment. And data from Gideon Kaplan in observational, I think it was observational case control studies. Yeah. So in RCT suggested lower delirium rates in the hospital at home arm. So a secondary sub-study within the trial is looking at the rate of delirium and the duration of delirium within hospital at home. So we think that may be crucial.
Thank you. There are one more question, yes?
Another one.
Dr. Inquitari?
Miguel Angel. Here we are trying to implement more hospital at home schemes. At least in Catalonia, you showed the way, let's say, but so we think that the results are great for the patients mainly, but actually we are experiencing a bit of struggle between primary care and geriatrics, which didn't really happen when the acute hospital at home, the classical, probably were implemented, but now somehow some of them feel threatened by geriatrician going into their homes, which for me, it doesn't make sense because hospital at home is an alternative of conventional hospitalization or post-acute hospitalization. What do you think we should do to, let's say, work together and make them see that this is not a threat, but is something that might help them?
Thank you, Marco, for your question. I think the answer is key. If geriatricians and GP collaborate, patients remain at home. So I think there is a clear solution. If we collaborate, there is an opportunity to maintain patients in the community. So no problems. We are focusing on patient needs and on patient opportunities.
Thank you. Only 1 minute, one more question. I have only last comment to Dr. Lopez Arrieta. There is no doubt that a comprehensive geriatric assessment in acute care is effective. There's no doubt, but it's not a bit deception that the benefits only remain for 3 months. It's possible to get better these outcomes.
We do not have an answer for that because we only have data according to these trials, but we are sure that these benefits are prolonged for more than 3 years, but we know evidence for that, so it's only our own perception of that. But we, as I talk about, we have the evidence, but we can reach the truth if we don't have good evidence. And so what we have is the only thing, the medium to reach a conclusion. But there is a subjective feeling that we are doing things very well, and maybe our results go beyond those times.
Okay, thank you very much. When I was younger, I worked in an acute care setting, and then in the first day, my thoughts were, oh my God, I don't want my patient dies. And in a few days, my thoughts were, I need to discharge quick my patient for a post-acute care. I don't have no time to interventions. No, sure, I was wrong, sure. Well, thank you very much. It's the time. We can finish the closing symposium. We have to think that we need more leadership and best bets. Thank you very much for all.